This session, developed jointly with the SCN and Manchester Cancer, presents an overview of supportive and palliative care and how this can be integrated into cancer care. We all know the landscape of cancer care is changing rapidly, and this is partly due to the advances in cancer treatment, and thus there are now an increasing number of patients at different stages of their illness who are living with cancer. These people may be actively receiving anti-cancer treatments, living with cancer and beyond, or living with advancing disease. Many of these patients, especially those with advanced cancer, will require the help of palliative care professionals who have expertise in managing a range of problems, whether these are associated with the cancer itself or as a consequence of the cancer treatment. Furthermore, there is mounting evidence that good palliative care, sometimes referred to as supportive care, delivered early can improve the quality of life in these patients, possibly even lengthening their survival and reducing the need for aggressive treatments near the end of their lives. Referral within the Christie for patients with these complex needs will be to the Enhanced Supportive Care Service, while services elsewhere are provided by community and hospital specialist palliative care teams and hospice services. So what is supportive and palliative care? Well, incorporating palliative care within cancer care can help patients with advancing disease to have a better quality of life through better pain and symptom control, by giving patients and their carers the opportunity to explore concerns and supporting them through complex psychosocial or spiritual issues, and giving support at the end of life and into bereavement. And what is important is that palliative care can run alongside and support patients who are receiving systemic anti-cancer treatments. Referral to palliative care should not be synonymous or restricted to end-of-life treatment. And you can see from this diagram that as the cancer progresses and the treatment options become less, that input from supportive and palliative care services may increase depending on the complexity of the situation and extends into the last days of life. This is an adapted version of the Northwest End-of-Life Care model. Patients can enter the pathway at the point of metastatic disease and often when they are receiving cancer treatments. This may be years or months before death. And as patients develop increasing morbidity due to advancing cancer, they may still be receiving active treatments, often into the weeks preceding death before entering the last days of life. Supportive care can actively support these patients and their carers throughout this pathway. So what do patients think of supportive care? Patient feedback. I got my life back. I had shut myself away from the people that I love due to pain and lethargy. But with the support of the supportive care team, I am able to live again. This week alone, I've been to the theatre and had afternoon tea with my husband, but I know where I stand in relation to my disease, but feel I am living. Mrs. C was a 60-year-old lady diagnosed with left breast cancer 11 years ago prior to her death, and she had a mastectomy and radiotherapy to the chest wall followed by hormone treatment. She developed bone metastases 4 years prior to death in multiple levels of the spine. 8 months before she died, she developed spinal cord compression at T12. At this point, she had radiotherapy to her spine followed by a chemotherapy trial. She was referred to the district nursing team with ongoing support from her GP and the local specialist palliative care outpatient clinic. Socially, Mrs. C had a supportive family and friends, but she was shocked by her condition, especially by the fact that she was struggling with mobility due to the spinal cord compression and pain and was no longer able to dance. She was shocked by the advancing and palliative nature of her condition, and she was concerned about what the future holds and no longer had a faith to hold on to. 6 months before her death, she was found to have further progression of liver metastases and underwent further chemotherapy. At this point, she was referred to the community specialist palliative care team. She had one admission to the Christie with neutropenic sepsis, general weakness and increasing nausea, and was referred to the physiotherapy and the hospital supportive care team, who helped to improve her symptoms of dry mouth and nausea. She recognised that her husband was struggling to cope with caring for her, but she wanted to be at home at this point and was becoming more depressed and tearful, and that her life felt unreal. And she was unable to share her concerns and fears with her family because this was too upsetting, wishing that she had died earlier. The supportive care team worked with the oncologist to help improve her quality of life and facilitate discharge at her wish in communication with the established community care services. Mrs. C's condition continued to deteriorate, and following further progression, she declined further treatment. She was referred to the community rehabilitation team, and consequently continuing healthcare funding was approved for increased support at home. But her and her family's wish was to die at the hospice, where she was admitted 10 days before her death. It's important to note that in many other circumstances, care in the last days of life may well have been provided at home. This case study highlights some of the benefits of earlier integration of supportive and palliative care within cancer care, and these include prevention of unnecessary admission to hospital, reduced time spent in hospital, the ability to preempt and minimise crises, better quality of life, and better patient and carer experience. And palliative care not only give direct support to patients, but also to the carers and healthcare professionals involved in the care. To access further support, please visit our website and refer to the guidelines on pain and symptom control, or you can access advice from your local hospital or community specialist palliative care teams or local hospice. So when should you think about referral to palliative care? Well, at the point of recurrence or at the point of metastatic disease, particularly where there are reduced, limited or no treatment options. Or maybe when the patient has complex pain or symptoms, psychosocial distress such as coming to terms with a poor prognosis, or they wish to discuss future care and wishes. And also for additional support for families where there are complex issues. It's important to note that much palliative care is and can be provided by GPs and community teams, but with additional support from specialist services when this is needed. So what are the responsibilities of the Cancer Board? Well, firstly, be familiar with the palliative and end-of-life care guidelines, know when and how to refer to your local palliative care teams, audit practice in your own disease groups, for example, evaluation of pain and symptoms, use of the guidelines, or point of referral to specialist palliative care services. And consider the impact on palliative care when developing innovative ways of working and service redesign. In summary, the key points are patients can be referred to specialist palliative care whilst having anti-cancer treatment. If patient symptoms are not settling, seek further advice. Facilitating discussions about future care can be challenging. Be aware of your own skills, knowledge and experience, and remember that families need the support too. There is substantial evidence that palliative care, when combined with standard cancer care, leads to better patient and carer outcomes. Thank you.